Hello and welcome. My name is Elizabeth Wade, and I have shared a short summary of my professional background at the end of these slides. The title of this presentation is Risk Reduction Strategies: Pulling It All Together. This is the relevant financial relationship disclosure for this presentation. These are the key abbreviations that will be used in this presentation. This is the learning objective that will be addressed during this presentation. We have covered a lot of information so far in the risk reduction strategy module. We've talked about system-based causes of error, looking at contributing factors, looking at the entire medication use process to address those latent and active failures and identify strategies. We then talked about what kind of strategies to implement with the 4 risk reduction principles. And finally, we looked at a lot of tools in our arsenal for risk reduction strategies, which you see here. Remember, we want to start from the top with the highest leverage strategies. And while they're the most effective and most long-lasting because they rely on systems and not humans, they're also the hardest to implement and are more likely to have unintended consequences. Remember that we want to implement low leverage strategies too, but definitely in combination with other strategies. And remember our fire safety analogy with our 4 risk reduction principles. We can do everything from preventing the error, and if then we can't do that, the next best thing is to reduce the likelihood, and then increase visibility, and finally mitigating harm as a result of the error. So let's take a look at a case with insulin U500, my favorite high alert medication. You'll notice that this patient is ordered for 30 units of insulin. Why are they on insulin U500? You've got me. You'll notice the syringe is filled to the 0.6 ml mark, but the order is for 30 units, which in U500 insulin means 0.06 milliliters. Well, okay, I do know why they're on U500 insulin. It was because this was what they were on at home. This patient came in for hypotension, and the patient was continued on home insulin U500. But after several days of not eating in the hospital, and frankly just being sick, the dose decreased to 100 units sub-Q each morning and 30 units sub-Q each evening. However, the patient was never transitioned off U500. Therefore, the pharmacy technician prepared a 30-unit dose for the evening dose in a 1 ml syringe and drew up 0.6 mLs of U500. This is equated to 300 units. A pharmacist checked and dispensed the dose. The patient happened to refuse the dose, thankfully, because his blood glucose was running low. It was only 45 to 89 milligrams per deciliter. Upon returning the dose to the pharmacy, a pharmacy staff member discovered the error. I'm going to have to give you a little bit more background on the organization in order for us to go through the exercise. The current process in this organization is that insulin U500 is available on formulary. Providers use a standard order set in order to order U500. Insulin U500 is dispensed as a patient-specific dose only from the pharmacy. Insulin U500 also requires an independent double check by 2 nurses for medication administration. Here is a picture of the order set that is used in the computerized provider order entry system to order insulin U500. It is a customized form. When the provider enters the dose, the form actually calculates the volume of insulin that the patient will need in order to proceed with the dose. Here are 2 contributing factors for this case to consider. The first one is that the dose decreased during the course of the patient's admission because of the patient need for insulin decreasing during their stay. The dose decreased to the point where the insulin U500 became very small and difficult to measure at 0.06 mLs. A second contributing factor to consider is that there was confirmation bias on behalf of the pharmacy technician and the pharmacist who prepared and checked the insulin U500 respectively. Both of them thought they saw 0.6 mLs as the dose. Now, during our identifying system-based causes of error presentation, we discussed that it's important to walk through the entire medication use process and consider risk reduction strategies at every step. In this case, we have the provider ordering U500, a pharmacist verifying the order, a technician preparing the syringe, a pharmacist checking the U500 product, and 2 nurses administering the U500 to a patient. There's several possible risk reduction strategies to consider when we talk about the prescribing step. When we look at the first principle of preventing the likelihood of an error, we could completely prohibit the use of insulin U500. This would be enforced by a forcing function by it not being available in the system to order, as well as by policy. Obviously, this would have higher unintended consequences for patients who really do have high insulin needs. A second principle is to reduce the likelihood of the error. Reduction strategies here may include a constraint or policy to restrict the use of U500 to a particular consult service, such as the diabetes service. We could also use an order set with decision support, which is automation and computerization. And finally, we can use a redundancy risk reduction strategy to have an automatic consult to advise on the U500 use. There are multiple considerations when thinking about all those risk reduction strategies. For example, the prevention strategy would be great, except there's a lot of unintended consequences with patients that have a clinical need to use insulin U500 with high doses. Therefore, in our organization, we did not implement that prevention strategy. We opted to use strategies that reduce the likelihood of the error. So we restricted U500 use to the consult service. This is a constraint and a policy. However, unintended consequences of this included that the consult service for diabetes educators weren't available 24/7. Therefore, there was sometimes a delay in care for patients who were awaiting consult. We already had an order set with decision support in place, which is automation and computerization, as you saw earlier. But perhaps we could have made this automation smarter by restricting doses that were too small to measure. And finally, we could have implemented a redundancy to automatically consult and advise on U500 use. This was the least of the unintended consequences and the lowest risk reduction strategy. Ultimately, this and the order set were the 2 strategies that we chose to implement. Now let's look at the next step in the medication use process. The pharmacist verifies the order, a technician prepares a syringe, and then the pharmacist checks the product. In order to increase visibility of a dosing error where the incorrect dose is drawn up, a failsafe could be gravimetric analysis with sterile compounding technology. This would greatly increase the visibility of the error and potentially prevent the error from proceeding further in the medication use process. When we look at reducing the likelihood of the error, we could use a specific syringe for insulin U500. This is a constraint. However, one would have to rely on human memory to actually remember to use the U500 syringe. We could use a U500 pen that's available from the manufacturer. This would be a constraint. And potentially we could implement an independent double check of the preparation in the pharmacy, which would introduce a redundancy that could be effective as long as it's done independently. Now let's talk about all those strategies that we just uncovered for the pharmacy process step. For gravimetric analysis, while this is a very effective failsafe, it's expensive to implement. There's significant resources for implementation. This is a major project, and would also have a significant impact on sterile compounding workflow. We ultimately did not choose to implement this in the short term, but this became something that we put in the long term as a roadmap strategy. The use of the insulin U500 syringe is available as a constraint, but that means we would have to have both the U500 and U100 insulin syringes available. There is potential unintended consequences with introducing both into our medication use process. We need to have something that reminds the sterile compounding room staff to actually use a U500 syringe. So now we're relying on human attention to the preparation and use of the correct syringe. We ultimately didn't think that this was going to be a very reliable strategy. We could use a U500 pen. An unintended consequence of this, though, is that there are other insulin pens on formulary that look very similar. There's also the risk of bloodborne pathogen exposure if the pen were to be used on more than one patient. And finally, we could implement an independent double check of preparation. The unintended consequence of this is that there's greater preparation time. Ultimately, And in the short term, we chose to implement the redundancy. And as a long-term strategy, we chose to think about gravimetric analysis. Finally, at the administration step, a strategy for reducing the likelihood of an error is a redundancy with an independent double check of the insulin administration. In this case, barcoding and other risk reduction tools would not have reduced the likelihood of the error. Unfortunately, there's no gravimetric analysis of medications at the bedside. In this case, this was already in place, and we just needed to make sure that it was being done effectively. Now that we've applied all of the information that we've learned to a patient case, I hope you see now how it all fits together. By identifying the system-based causes of error, we look at contributing factors, and we pull the risk reduction principles and tools from our arsenal to aim for the highest leverage risk reduction strategies possible without causing unintended consequences. The best sources of risk reduction strategy ideas include those involved in the medication error, any frontline staff, and having a group discussion to get more brains around the solution is always a good idea. These are the references used to develop this presentation. Thank you very much for your time and participation.